Welcome to the session of staffing models. In this session, we will learn how we structure, allocate, and manage healthcare personnel. Staffing is the most significant investment in your department, often consuming more than 75% of professional expenses. It is very integral for patient care and operational flow. This session helps leaders determine staffing needs, optimize current staff, and explore different staffing models. Several key factors influence departmental staffing. Higher volume allows for greater efficiency and segmented patient flow. Sicker patients require more staffing time and expertise. Long length of stay reduces bed availability and strains your staff. Experienced providers improve efficiency. The non-physician roles is how extenders are used affects overall staff load. Boarded patients. These occupy the emergency department beds requiring continuous monitoring. Goals like door-to-doctor time influence staffing intensity. Variability in training impacts workflow and delegation. To build your strategy, you have to understand your department's patient arrival or admission trends by hour and day, benchmarking goals, patients per hour, length of stay, left without being seen, workforce availability, skills, retention, training gaps, operational priorities, safety, satisfaction, throughput. Start with data, volume, acuity, relative value units, and satisfaction. Build your schedule based on demand curves. Identify peak periods and adjust staffing accordingly. Asset velocity refers to patients seen per provider per hour. This is an example from the emergency department. Standard 2 to 2.5 patients per hour. Above that, risk burnout and errors. Consider flexible shift lengths, 8 to 5 hour shifts. At peak hours, need more coverage. Effective scheduling balances demand, clinician preferences, and fairness. Add more staff when turnaround times increases, left without being seen exceeds target. On busy days, these become the unpopular shifts. Clinician burnout rises, satisfaction scores drop. Differentiate routine fluctuation from rising long-term demand. Create surge capacity plans with clinician and nursing agreement. Use the least expensive resource that gets the job done safely. With certain protocols, primary care providers can see up to 75% of cases. Physician extenders can manage 25 to 35% of cases independently. Scribes boost provider speed and documentation. Senior residents provide net gain. Juniors often slow workflow. In resource-limited settings, use standard operational policies and protocols to streamline care. Ask these 5 questions. What is the incoming volume? What is the workload per patient? What is the patient's acuity? What metrics are you tracking? And what are your performance priorities? Build schedules by trial and error, then refine using computer-assisted tools to ensure fairness across weekends, nights, and holidays. Effective backup must have clearly defined thresholds, include support staff, not just physicians, be tested and agreed upon in advance. Otherwise, on-call clinicians will be underused or ineffective. Nurse staffing is a key constraint. Physicians may be the scarcest resource, but not the most valuable. Nursing determines flow and function. Benchmark how many hours of direct nursing per patient Communication and collaboration between roles is essential. Scribes can improve patient seen per hour, increase relative value unit production, improve documentation and coding, and they boost satisfaction. A scribe pays for themselves if they help a physician see a couple of extra patients per shift. Academic departments must balance patient care, education, research. They require a shared vision and mission, data on patient types and needs, educational time built into staffing models, evidence-based medicine protocols for consistency and safety. Teach not only clinical skills, but also human connection, service, and communication. This is a case study in which the steps were to collect hourly and daily arrival data, plot patient demand curves, compare demand with current staffing, adjust staffing and hours to match ramp-up times. Outcome: smarter scheduling, reduced mismatch, better resource use. This is another case study where the problem identified was inefficient staffing led to long length of stay. Solution: merging fast track and pediatrics. Outcome: length of stay decreased and door-to-doc time improved. In conclusion, smart staffing isn't a guesswork, it's a strategy. It means matching staff to real demand, adjusting for acuity, balancing cost and care of quality, creating flexibility and surge plans, empowering every role from physician to scribe. Because when staffing works, everything flows. Thank you for joining us in this session for staffing models.